morning, good afternoon, good evening, Spot the TV breakfast host to start with. Welcome to another great session where we are aiming to get as many as your COVID vaccine questions answered. Welcome to the Doherty Institute for Infection and Immunity, the Murdoch Children's Research Institute and the Victorian Chamber of Commerce and Industry to COVID-19 vaccines. Your questions answered, part 2. Part 1 was such a hit, we're all back by popular demand. My name is Michael Rowland. At the other part of the day, I do represent ABC TV's News Breakfast program, and I am once again delighted to be the moderator of this all-star panel once again. I'd firstly like to acknowledge the traditional owners of the land on which we all gather, no matter where we are in Melbourne and across Australia tonight, and pay my respects to their elders, past, present, and emerging. So much has changed since we last gathered in person for the first part of this Q&A session. Australia is no longer aiming for COVID-0, but there are so many burning questions I know all of you out there have as we hopefully approach the end of the pandemic as we hit those 70 and 80% thresholds around the country. So we want to get to as many of your questions as possible over the course of tonight. So I'm going to keep these initial introductions as briefly as I can. The Doherty Institute continues to be at the forefront of the pandemic response, a joint venture between the University of Melbourne and the Royal Melbourne Hospital. The Institute was purpose-built to bring together experts in infectious diseases and immunology in order to find solutions to prevent, treat and cure infectious diseases. The Murdoch Children's Research Institute, or MCRI, is the largest child health research institute in Australia. Over the past 18 months, MCRI has made a number of very important contributions to the world's knowledge around COVID and its effect on children and families. We also want to welcome the Victorian Chamber of Commerce and Industry for partnering with us this time around. The Chamber is the largest and most influential non-for-profit business organisation in Victoria, informing and supporting 47,000 members and clients across the great state of Victoria. They proudly champion business interests and have been a fantastic advocate for their members throughout the pandemic. We'll hear from their Chief Executive, Paul Guerra, very shortly. Tonight, we are going to try to traverse as much as we can across the broad field of questions from booster shots to COVID in kids, vaccine in kids, the different types of vaccines available, the intervals between vaccines, and overall the importance of getting as many Australians vaccinated as possible, and equally importantly, overcoming sadly still, some of the misinformation out there. So many questions already on those various fronts, but we encourage you as well to contribute live questions as we go along via the live chat forum here on the Zoom session. I want to introduce our panel, starting firstly with Professor Sharon Lewin. Sharon, as you would all know, is the director of the Doherty Institute, a very prominent face over the course of the pandemic. She is an internationally renowned researcher in HIV cure and is also an infectious diseases physician. Sharon is also the chief investigator of the Australian Partnership for Preparedness Research on Infectious Diseases Emergency, or APRISE, that aims to bring together Australia's leading experts in clinical, laboratory and public health research to address the key components for a rapid and effective emergency response to infectious diseases. Sharon, hello, great to see you. Please also welcome Associate Professor Margie Danchin. Margie is a consultant paediatrician at the Royal Children's Hospital and an Associate Professor and Clinician Scientist at the University of Melbourne and the Murdoch Children's Research Institute. As the leader of the Vaccine Uptake Group, Margie's research focuses mainly on vaccine confidence, acceptance and uptake, particularly amongst high-risk groups and in low and middle-income countries. And again, Margie, it's great to see you as well from a distance. We also have Professor Terry Nolan. Terry is a paediatrician and clinical epidemiologist and the head of the vaccine and immunisation research groups at both the Doherty Institute and the Murdoch Children's Research Institute. Terry's research has been principally in immunisation and clinical trials of new vaccines. Terry also has considerable experience in working with both Australian and New Zealand governments and with the World Health Organization in the provision of highly sought after policy advice. Terry, great to see you too again. And also finally, Dr. Janine Trevelyan is the head of the clinical virology and HIV services at Austin Health here in Melbourne. She is the lead of the Austin COVID-19 Vaccination Hub, responsible for coordinating vaccine distribution across the northeastern region of Melbourne. Janine is an infectious diseases physician and clinical researcher whose work focuses on understanding and preventing long-term complications of viral infections, and in particular the effects of HIV. And can I say to all gathered here, Janine has come to us straight from working on one of Austin Hospital's COVID wards today. So Janine, thank you for that, and great to see you. As I mentioned, we have a lot of questions to get through, a lot of back and forth with our panellists, but I first want to hand over to the Chief Executive of the Victorian Chamber of Commerce and Industry, Paul Guerra, to make some opening remarks. Over to you, Paul.
Thank you very much, Michael. The Victorian Chamber is absolutely delighted to be partnering with the Doherty Institute and the Murdoch Children's Institute on this incredibly important event. You mentioned it's part two. It's part two for a reason, because there's so much interest. I'm joining you today from the lands of the Wurundjeri people, and I wish to acknowledge them and pay my respects to their elders, past, present, and emerging. I'd also like to recognise any Aboriginal or Torres Strait Islander people joining us today. On behalf of the Victorian Chamber President, Karen Sobels, who is joining us online tonight, I'd also like to formally thank and recognise our health sector heroes and all the work that you've done over the past 18 months to keep us safe. You're just incredible, and I'm looking forward to hearing from some of our leading health experts tonight. Businesses, well, the people they employ and the communities they support have been absolutely devastated and decimated through this pandemic. As we speak, about 140,000 businesses in this state are currently receiving government support just to keep going. Throughout the 6 lockdowns, Victorians in metropolitan areas have endured 325 days wearing masks outdoors, 125 days homeschooling, 91 nights under curfew. Cinemas and theatres have been closed for 290 days. You haven't been able to get a haircut for about 140 of those days, and it probably shows on me tonight as well. Restaurants and cafes have been takeaway only for 276 days, and pubs have been shut for 207 days. Businesses desperately want to get back to work, to welcome their customers and staff back, and we know that the key to making that a reality is to get vaccinated. The light on the hill for business is to get to 70 and then 80% vaccination levels. That's when we should start to see easing of restrictions and leave statewide lockdowns in the rearview mirror once and for all. We can't wait for that day. I speak with business owners every day, and they want to contribute in whatever the way they can to make that 70 and then 80% a reality. And that's why we've got so many Victorian Chamber members on tonight. Information and knowledge are the greatest weapon in the fight against COVID, and that's what we are going to arm ourselves with tonight. It's going to be a great session. So with that, back to you, Michael.
Thank you very much, Paul. Now, as we mentioned, we have plenty of your questions already, but please do not hesitate to contribute questions via the live chat portal on your Zoom screen. And please, if you'd like to get involved in sharing this event on social media, please do. You can use the hashtag COVID-19 Q&A, all one word, hashtag COVID-19 Q&A, and make sure to include the Twitter handles at the Doherty Inst, at MCRI_for_kids, and at Vic Chamber. So many questions. Let's dive into it first. And Sharon, I want to start with you. It's an obvious question. I think it's a question we need to ask first and address first. We are so much better placed to get out of the pandemic than we were when we last met 6 months ago, when the vaccination effort really hadn't started. I just had a quick look. We're up to about 47% double dose across Australia. How important is the next 1 to, say, 3 months in terms of the vaccination effort? Vaccination is the ticket out of here. How important is it that Australians get behind this vaccination effort?
Yeah, thanks, Michael. In short, super important. It's our only way out here. Last year was a very different situation, even though as a Melburnian, it feels like the same, sitting here in September and everything closed and people desperate to open up. But last year we had a totally different virus, the Wuhan strain. We managed to crush it just with public health interventions alone, and we had no vaccines on the horizon back in September or October. We're now in a totally different situation with Delta, which is much harder to control with public health measures, and really effective vaccines. But the vaccines have to be at very high rates to start having a big impact on reducing hospitalizations, deaths, and transmission. And the most important thing we want to do now, as we all want to open up, and I should just say the situation where we're in now the measures are working. There's no doubt that these strict measures are making a very big difference. We've seen how Delta just can rip through populations like we saw in India, Thailand, the Philippines, etc. So it is working, but the added benefit of vaccination will be huge, but we really only see that major benefit kick in at 70% double vaccinated, probably even more so at 80%, and even, I hope we can get even higher. Australians have traditionally taken up vaccinations. Our childhood vaccination rates are super high, and I just hope that people realise how good the vaccines are, how safe they are, and what a big impact it will make to all of our lives. So vaccination is everything, and speed, particularly right now, is super important in the situation we're in Melbourne at the moment.
Terry Nolan, what would you say to people who, for whatever reason, are still a bit too complacent about getting their vaccine? Okay, we're up to 47%, we'll get to 70% in a month or so. I can probably wait until whenever. What do you say about I guess the urgency of action right now?
Yep. Well, the time for waiting is over, is what I say. We've been waiting since January, and we were very lucky, also helped by a fantastic public health response to suppression of the virus. But we were very lucky that we weren't overwhelmed from the start. But in a sense, I think we became too complacent. I felt, oh, one day it'll all be fine, we'll sort all this out. But what I don't think many of us realised was how profound it was for the economy that getting on top of the virus was so important. And we all now probably, my quip about this is that in the first year we all became epidemiologists. Earlier this year we all became vaccinologists, and now we're all becoming mathematical modelers. But the modelling has shown that it doesn't make actual predictions, but it actually shows what we need to do to get out of this. And you'll hear from everyone now, there is no escaping the fact that we have to have very high levels of vaccination. The levels that have been used in the modelling are artificial in the sense that they were constructed as potential signposts for when you could start to release enough of the social constraints and open up so the system wasn't overwhelmed. But that doesn't mean they're the target. The target for vaccination coverage for our community has to be the same as we've set for our children. And we've done that 25 years ago in setting a target of 95% for our children's vaccines. And we've been through many different ways of actually making that happen, and we have made that happen now. If it's good enough for our children, I argue it's good enough for the rest of us as well to aim for those very high targets to make this work properly and be durable for the long term.
I want to get to you, Margie Danchin, on the issue of vaccine hesitancy, one of your expert areas. But Janine, I want to get your thoughts on this as well. And also tell us what you're seeing at the coalface, at the front line of the COVID effort, working in the COVID ward, and why you think it's so important for that vaccination effort to ramp up as quickly as possible.
Yeah, thanks, Michael. It is striking for us here in the COVID wards. We have big whiteboards that list some of the key characteristics of each patient, and we include on that the vaccination status. And it is nearly always 0, 0, 0, 0, 0, 0, and occasionally it's first dose. But none of the people we're seeing, particularly in our intensive care, are people who have had the double doses. There's the very odd person that happens to who has a very low or suppressed immune system and hasn't responded to the vaccine, but you really, I sort of wish I could show you it all without, letting people's privacy go. You can really see it is incredibly striking that the vaccines are keeping people out of hospital and, most importantly, out of intensive care. And that is absolutely critical because, as Sharon has said, we can't rely solely on public health measures to control the Delta variant. It will come, people will be infected with it. So the only thing we can do is protect our hospitals and ourselves by getting vaccinated. The time of choosing whether I'm going to wait for my preferred vaccine preference has passed now, and it's a decision between COVID or getting vaccinated. There is no wait time anymore.
Margie, I want to go to you, but also use the opportunity to bring in a question, which is a distillation of so many questions along the same line. The question is, how do you explain to people who are not scientifically educated, in layman's terms, that vaccines are safe?
Yeah, thanks, Michael. And, I think unfortunately now we're seeing coverage really increase, but people still do have lots of questions. And as you've just highlighted, the most common question is still, are the vaccines safe? And I think, what we have to realise if we take a step back is that more than 5.7 billion COVID vaccines have been given globally, and that we have a huge amount of data that we have from overseas, internationally and Australia, where we're tracking the safety of these vaccines. And so we really are monitoring the safety all the time. So we can reassure people that we have so much information, both from the clinical trials and from the real world data now, both about the common and expected side effects, as well as those more rare and serious adverse events that we're all used to discussing now with the AstraZeneca vaccine and the clotting syndrome, or potentially the heart inflammation and the Pfizer vaccine. We can talk about those things, but just to reassure people that, there's a huge amount of data we have now on safety, and we can reassure people that these vaccines are extremely safe.
To another question, and by all means, if anybody wants to buy in on this, I know, Margie, you're in this field every day. What work is being done to address hesitancy in vulnerable regional populations? And I'll extrapolate from that, and we all know the great issue in boosting vaccination rates amongst Indigenous communities. Where are things at, and what more needs to be done to overcome those hurdles? Maybe you want to start, Margie, and then I'll toss it around to the others.
Yeah, so we know that there are different concerns that are held in different communities and groups, different cultural groups and Indigenous communities, also in lots of industry groups, and even healthcare workers themselves have questions. So you're talking about regional areas. I think people still are asking about, vaccine safety, how well the vaccines work. Unfortunately, there are still some conspiracy theories that are circulating, particularly around things such as fertility for women, or whether the vaccines have been developed too quickly, or whether the mRNA vaccines can be inserted in people's DNA. We're still needing to address those questions and to reassure people. And I think now people really need simple, clear facts and lots of community engagement, clear communication to sort of address these questions. But we do need to take the time to try and understand what the concerns are in these different communities.
Would anybody else like to buy in?
Yeah, I'll jump in too. I totally agree with everything Margie's said. I think what we've really found as a vaccine service provider is that getting buy-in and leadership from community groups, it's an internal out now process, rather than me and my team coming to people and saying, here's this resource we've developed, or here's me coming and talking to you about the vaccine. It's about a particular group looking at, in leadership within that group, who then come out and reach out to us, or that we're able to say, look, are you able to be the person who can help express this information? Because as Margie said, it's about the right language, not just the right information. It's easy for us in some ways to provide this information. The vaccines are very safe, the vaccines are very effective. They're kind of the big ticket items. But I think a number of these particular groups need to hear that from somebody that they trust, and that's been incredibly effective at increasing vaccination rates in particular groups. The Victorian Aboriginal Health Service, for instance, in Melbourne, has done an extraordinary job at handing out a large number of vaccines to Aboriginal and Torres Strait Islanders here in Melbourne, as just one example. And that's really about leadership from within the particular cultural group that's led to that outcome.
And Michael, if I must just add one more thing, we've been working very closely with the Department of Health on a program called the Vaccine Champions program, where we've been engaging with many of these different communities and having town halls like this, Q&A sessions, where people have an opportunity to express their concerns. And a lot of those people attending those sessions have gone out into communities and run sessions themselves. So, because as Janine said, it's the community and the faith leaders from those communities that people want to hear from and be reassured by. So I think often this sort of forum where you can actually answer questions is the most powerful way to address concerns.
We've got lots and lots of questions on booster shots. I want to turn it back to you, Sharon Lewin. Will we need, and again, this is a compilation of so many questions along the same theme, will we need booster shots for those of us who've been double vaxxed already?
Well, short answer is the information's still emerging. And I like to think of this as a third dose, not necessarily boosters. So many vaccines that we use, for example, hepatitis B, we use 3 doses. You need 3 doses to really get your immunity up to a high enough level that it can last for years. And then there are other vaccines like the influenza vaccine where we have a booster every year because the virus changes every year. So we don't really know about boosters yet, but we know more and more about third dosing. And we know the most in Pfizer. So most of the work has been done with the Pfizer vaccine. And we know a few things that are clear. The first is that if you're immunosuppressed, you've had an organ transplant or you've had cancer chemotherapy, a significant percentage of people don't respond that well to actually either vaccine. So it's looking more and more clear that a third dose will be needed for people with immunosuppression. I should say at the moment in Australia, we're not doing any third doses or boosters. Our technical advisory group, Margie sits on that group, are reviewing all this. I'm almost certain that we'll be in line with the rest of the world, but at the moment, there are no boosters available in Australia. So just yesterday, the recommendation to in the US was that third doses should be given to people who are over the age of 65, and that already recommended immunosuppressed people. And then you have other countries that are rolling out third doses to everyone. And I'm not so sure we've got all the information we need to say that everyone will need a third dose. It's looking like if you've got an underlying immunosuppressive illness, 2 doses aren't enough to give the immunity you need, at least with Pfizer and also probably with AstraZeneca. In older people, we've got some very good data coming out from Israel that over the age of 60, the additional booster helps protect against infection and also reduces your chance of hospitalisation. But whether we need to open it up and give it to everyone, we just don't know. And surprisingly, less information is around for AstraZeneca. But what we do know is that the protection against hospitalisation and death for people that have had Pfizer, Moderna or AstraZeneca really does last. And it's probably only a subgroup that lose the impact of that vaccine. If I was going to predict the future, I don't think everyone will need a third dose, but there will be some groups that will need a third dose. And it's an emerging issue in Australia.
Terry, have you got thoughts on
that? Sharon's pretty much said it all. Though I guess the first comment should be we should be still talking about the first and second dose before we start worrying about the third dose. That is just such a critical issue. But I know a lot of people are thinking about that, particularly those who are lucky enough to get their first and second doses much earlier in the priority groups around the country. A number of countries have announced that they are moving to third doses. Israel, as Sharon just mentioned, effectively have a third dose for everyone over 30 years of age. And the early data from there shows, and we'll learn from this because we're behind these other countries, the early data from there shows that it does add considerable benefit in those who've received it. It's still early. The British only announced a few days ago a third dose policy for those, I think, over the age of 50 and those in special groups, immunosuppressed and so forth. And the Americans look like they are going to move to a subgroup third dose recommendation of those with those over 60 and also those with immune compromise. So I do think it is inevitable we'll move to it. The two issues are waning immunity just because over time all vaccines may lose some level of their protection. And second, with the variants that have emerged, whether there's some escape from protection from the vaccine, whether it's necessary to have either an additional dose of the same strain targeted vaccine or potentially a third dose with a specific strain variant. And all the manufacturers are working still on clinical trials with those variants. There are some theoretical problems of having variant-directed boosters that may in fact mean they might be less effective. They're theoretical issues. So again, back to what Sharon said, there's a fair bit still to be worked out in the research, but it all is going to appear fairly quickly. Planning and thinking about is important, but not at the expense of just getting that first and second dose done here as quickly as possible.
So many questions about variants. I'll kick it over to you, Janine, and for that matter, anybody else can buy in as well. How likely, having survived or still fighting Delta, will we get through this and have to deal with a potentially even more dangerous variants next year or at some stage in the future?
Yeah, I mean, we don't know, obviously, is the answer, but also that as soon as our borders are open, we will be expecting to see new variants of COVID coming into Australia, and I think we have to be ready for that. The chance of new variants being generated is really a factor of how much viral replication, how many people are catching COVID, and how that's going on. And that's really happening outside of Australia's borders, because we have managed to suppress our amounts of infection to a level that doesn't foster that sort of development of variants. But, obviously that's going to continue to happen in other regions around the world that don't have high vaccination rates at the moment. What that will mean, we don't really know. It's not a guarantee that a new variant is going to be more deadly or more contagious. Sometimes they're just different in different ways. And we've seen that really with Delta, that yes, certainly more easily to transmit, but not necessarily that significant increase in severity. So we will just have to deal with them as they come. I think it is unlikely that any variant will have a complete vaccine escape. So, for instance, taking us back to where we were last year when we didn't have a vaccine. So someone like myself who's had 2 doses of vaccine, even if there is a new variant that perhaps is not as protected by those vaccinations, it's unlikely that the population effect will be the same as having, the vaccine is still going to be having some efficacy, but perhaps not to the same level as we're seeing with alpha variants, for instance.
Can I just add to that, Michael? I agree with everything Janine said. Variants emerge largely because they have some sort of advantage in a population, and Delta acquired this sort of supersonic kind of capacity to be more infectious, and so it just slowly, took over everything around the world. But I heard a very sort of comforting words from Eddie Holmes, who's an evolutionary biologist, sort of one of the best in the world, located in Sydney, actually. Eddie was responsible for the first report that this was indeed a coronavirus. And he said, from an evolutionary biologist perspective, and he's worked on every virus you could think of, his prediction is that it's very unlikely we'll see a new variant that makes people sicker. So people shouldn't be worried about getting this new and deadly variant, because it's not in a virus's interest to be super deadly, because that means you can't spread anymore. So his prediction of the future is, as the world gets more and more the world gets infected and has some natural immunity, more of the world gets vaccine protection, the push towards the virus will become milder and milder. So from a sort of a bird's eye view, that's where we think this will go. So people shouldn't be petrified that, what's next, I mean, Delta, COVID has kicked up some curveballs for all of us, but the prediction is that we're not going to see something that is, deadlier and deadlier. People should not panic about that.
That'll reassure so many people, Sharon, because as I said, I lost count of the number of concerned questions about variants in 2022 and 2023. Just before we leave boosters, a live question from Fiona has come in asking, for argument's sake, that if she is double vaxxed with AZ, does her booster, and I know it's potentially, given everything that's been said, putting the cart before the horse, will her booster need to be AZ as well, or can it be an mRNA vaccine, looking ahead?
Well, I might answer that. Most of the studies have looked at the same sort of vaccine for first, second, and third doses. But there have been other studies that have mixed and matched, and from an immunological point of view, mix and matching gives you pretty good and it really sort of it heightens your immune response. So we don't yet have the data of comparing different ones. If you've got a third AZ, there's some data saying that that's actually safe and also immunogenic. But the direct comparison, if you've got mRNA or AZ, is not available for a third dose. That we have some of the data on the second dose, we're not of mixing with the third dose. I predict actually that the third dose we could mix and match, but we still need the studies to support that.
To another question that's come in from Jessica, if speaking of people who are immune compromised, if your immune system is predispositioned for autoimmune disease, as I've been told, as is my case recently, is it more likely that my immune system may not cope with a vaccine or have an adverse effect if I have a vaccine, if I do have immune compromised issues?
I can jump in and do some of that. I think when we're talking about immunocompromised people, we're talking more about people, for instance, who had an organ transplant or are having chemotherapy for cancer, and their immune system is heavily suppressed and so are unable to mount the normal response to a vaccine or, in truth, to a virus itself. Whereas the situation that the question is asking is about a dysregulated immune system, an immune system that is still working and is working pretty well, actually, and it's just perhaps a little bit more active in particular areas, and that's what causes autoimmune disease. So actually the autoimmune diseases themselves are not always immunosuppressant. Now, sometimes the medication people need to control those is a problem in terms of reducing vaccine efficacy, but the disease by itself is not always. And so most people with an autoimmune disease will be able to mount a good response to a vaccine, and they're not more likely to have an allergic reaction, for instance, to the vaccine. We've had many people come through our clinics and have them very safely. So it's an individual question to do with the type of disease and the type of medication that you're on, but in general, those people should absolutely get vaccinated and they're likely to get a good response.
And Michael, I might just add to that, because we often get asked that question for children as well, whether or not the vaccines are safe in kids who have autoimmune diseases. And what I would encourage parents listening to do is to go and discuss their child's autoimmune condition with their doctor. And as Janine says, you know, in the most part, it's incredibly safe, but it's still, if people have concerns, good to discuss the individual underlying condition with a medical professional, I think.
And speaking of underlying conditions relating to kids, and I'll stick with you, Margie, for this one. Another question sent in the last couple of days. Are vaccines safe for children 12 years and older who happen to have serious food allergies?
Yes, they are safe for them. And we know with the vaccines used in adults, in terms of anaphylaxis, that people who have anaphylaxis to certain foods or environmental allergens are no more likely to have an anaphylactic or severe allergic reaction to the vaccine. So, in fact, there's no clear correlation between food allergies and allergy to the vaccines at all. And obviously all people are observed for at least 15 minutes. And if there's any concern, people are observed for 30 minutes or a bit longer. So there's nothing to suggest that someone with a food allergy would react more acutely to the vaccine.
Lots and lots of questions relating to kids and the vaccine and COVID. I want to get to those as we progress through the conversation. I want to stick to vaccines. Lots of questions along these lines as well. And I'm distilling a few of them into this single question. As we have these extra vaccines like Moderna now arriving in Australia. What is the difference, if any, between Pfizer and Moderna?
I might have a go at answering that. First of all, they're both mRNA vaccines, so they're made the same way, giving your body a message to produce bits of the virus and create an immune response. Doesn't get integrated into your host DNA, and novel vaccines, which we have seen, are very safe. The interval between administration of the vaccines is slightly different. Moderna is 4 weeks, Pfizer's 3 weeks, although we have altered the interval from 3 to 6 weeks. It varies a bit around the country, but the original studies were done at 3 weeks and at 4 weeks for Moderna, 3 weeks for Pfizer. And most of the US has been immunised according to that schedule. There's emerging data that a longer gap in those mRNA dosing might be better for us, but officially it's 4 weeks for Moderna. The Moderna vaccines dosing is slightly higher. So it looks like the immunogenicity might be slightly higher for Moderna and looks like it's more durable perhaps than Pfizer. Whether that's because of the 3 week and 4 week gap, whether it's because the actual dose of Moderna is unclear. And the Moderna have made booster doses as Pfizer have, and they've reduced that dose a bit. So the Moderna looks very, very good. I actually can't comment on the myocarditis incidents, but maybe Margie might comment on that, because that's the one concern that people have around Pfizer, causing some heart inflammation in young people, largely young men, which is largely reversible and quite rare. I don't know, Margie may want to comment about what that is with Moderna and the difference in profile for myocarditis.
Yeah, sure, I can comment on that. So a serious but rare side effect from the mRNA vaccines that has been identified in young men, so particularly boys between the ages of 12 and 30, after the second dose of an mRNA vaccine can get inflammation of the heart muscle or the lining around the heart, so myocarditis or pericarditis. And in fact, when you look at Pfizer and Moderna, there's less data on Moderna in younger men because the highest risk age category is 16 to 17-year-old boys with the Pfizer vaccine. But having said that, the risk is around 30 to 70 cases per million doses. So you're still talking about an incredibly low risk, and there's more data being gathered on Moderna, but it actually looks very similar. And in terms of the myocarditis, as Sharon said, fortunately, it is mild and self-limiting, so it appears about 5 to 7 days after the second dose, as I said, with a bit of chest pain or shortness of breath. The boys might need admission to hospital for 1 or 2 nights, but the management is largely conservative, a little bit of anti-inflammatory medication, but they've all made a completely full recovery and there've been no deaths. So fortunately, even though it is, a serious side effect that we're monitoring very closely, it is mild and self-limited. And there doesn't seem to be a big difference between the risk with Moderna versus Pfizer.
A live question, speaking about intervals between vaccines, from Carol Grenfell. Carol, thank you for the question. And she asked, why has the emphatic 12 weeks between the 2 AZ doses been reduced to 6 weeks? Terry, you want to bite on that one?
Sure. The 12-week recommendation came from the initial English study in a relatively small number of people and with very few serious events. It did look like stretching it out, and this is, Sharon mentioned this before, but there's a principle for many other vaccines. Increasing the interval between doses will often actually improve the immune response. However, that improvement in the protection level for the AstraZeneca vaccine was not dramatic. And so that's why a general recommendation at a time when I think, again, mistakenly, we felt we could take our time about this, stretching it out to 12 weeks was made. But also the other thing it does is make more vaccine available for people to have their first dose. Obviously, as you shorten the interval, you have to bank, if you like, the second dose and make it available for those who've had their first dose. More recently, there's been a huge US study done with the AstraZeneca vaccine, much bigger than the English study, with a 4-week dose interval. And it showed very, very good vaccine efficacy with a 4-week interval. So reducing it down you're not trading off very much, if anything, in terms of vaccine effectiveness. And what you're doing is buying time to have a much shorter period before you complete that second dose. So there's a very strong argument for doing that at the moment around the country, down to 6 weeks, as happened in Victoria. Frankly, I think it could even go to 4 weeks, but really at the moment, having it at 6 weeks makes a lot of sense, and it doesn't reduce safety and it doesn't materially lose anything in terms of effectiveness.
Quite a few questions that spring from what I guess can be kindly described as the mixed messaging around AZ along the process. And again, I'm just choosing one of them along these lines. Will people over 70 get to choose other vaccines, or will AZ continue to be the only option for this cohort?
I might be able to speak to that. I don't know, I'll throw to you in a sec, Terry, but I think at the moment, as we know, AstraZeneca is still the preferred vaccine and recommended for people over 60, but I would hope as supply increases and we have more mRNA vaccines and other vaccines that come in, that we would be able to broaden that recommendation and give people choice. We certainly have seen that in other states. In Victoria at the moment, unfortunately, people don't have a choice over 60, but I don't think it's unreasonable, should the supply increase enough, that people should be given a choice. But I'll be interested to hear what Terry says.
No, you've all heard the Premier and others say the best vaccine you can get is the one that you can get today. And that's true. I think ultimately giving, if you like, this discretion for a public program in the face of an emergency just creates delays and creates difficulties. And I think, unfortunately, that's where we are. And I do hope, we've all heard the Premier on Sunday say that there appears to be a glitch with the Pfizer supply for next month. hoping that the feds will sort that out. We are very dependent now on having this long promised substantial increase in both Pfizer and Moderna supply to actually allow us to really get things moving. Doing anything to slow down already what the projected 2-dose completion targets are would be, I think, really, really disappointing. So I think we've got to keep the momentum going. I do know at the moment, or what I understand is that those who are getting their first dose AstraZeneca amongst those over 60, for example, who are not yet immunised is a very small proportion. And I think that is really unfortunate. They're people who could be protected today and have their second dose. There's plentiful vaccine available. And I honestly think they should go ahead and get that done.
Yeah, I was just going to add to that. You know, I really understand how confusing it has been for everyone with the changing directions. A lot of, at the beginning, you know, doctors coming out saying AstraZeneca is not as good as Pfizer, and this sort of super mixed messaging. And AstraZeneca has really held up. I mean, now it's in the real world, we're seeing how it is acting against Delta, how it's preventing hospitalizations and deaths in the UK. It's doing really well. I mean, managing that you know, there was the small risk about the blood clots, which we know is incredibly small, 1 in a million chance of severe outcomes and death. But we've become very good at picking it early in Australia, but it works, you know. So if I was over at the age of 60, given we're battling these supply issues currently, and there's no choice for people, you know, we can't, we much prefer, for example, for kids, you can't give AstraZeneca. That's the only vaccines that are being tested in the 12 to 15-year-olds are Moderna and Pfizer. But AstraZeneca has really held up, and it may be, and I'm fascinated by this as someone interested in viral immunology, is the type and quality of the immune response is very different than mRNA. So I'm quite happy about AstraZeneca. Well, I probably didn't say that a year, you know, like earlier in the year, but, you know, it has held up with the studies to look very, very good.
And can I just quickly add to that, Michael? Sorry, just also that the clotting syndrome that has been identified in people over the age of 60, in the most part, is milder, and it's being diagnosed earlier and treated earlier. So the outcomes are really good. So as Terry and Sharon have said, if the recommendation is still AstraZeneca, that's what people should go and get. And we've only had 10 cases of the clotting syndrome after the second dose of AstraZeneca. So incredibly low risk. So I absolutely second that, you know, if AstraZeneca's what's available, that people should go and get it.
Do we worry though that those mindsets have been changed for good, so that, you know, AstraZeneca is bad when we know it's not? It's great, and Pfizer and Moderna is better.
I hope we can change that. I think the message is whatever vaccine you can. We're in, you know, a crisis now. I can't, you know, the 2 biggest cities in the country are closed for business. You heard from Paul before about the immense pain that it's causing everyone. I don't need to tell people this, the impact on young children, on schooling, on the business community. We have a way out with 2 excellent vaccines, 1 in plentiful supply. So I just think that early machinations was in an environment where COVID was theoretical for us. It's no longer theoretical. And we've had the benefit of seeing this in billions of people, including particularly in the UK, that have had exactly the same strategy as us, AstraZeneca and Pfizer. Absolutely superb tracking of the impacts of those vaccines from the UK. The UK have not been perfect in many other ways, but their data systems have been extraordinary, and we're learning so much from it. And we're now learning about durability of immunity and durability of protection, and AstraZeneca is looking great.
And Janine, you made the point earlier, but it's certainly worth repeating. You don't see too many fully vaccinated people suffering really badly in ICU units, do you?
No, absolutely not. You know, almost none really is the answer. Or, you know, only one person who's been double vaccinated has come through my hospital recently with COVID. And I think Sharon's point is really important, right? That AstraZeneca has stood up to the evidence, right? When it started, we were having theoretical discussions about bit better, bit worse, bit more of a side effect, and now we have real good evidence. And I feel a little bit confident we can change some of this discussion. Just having had discussions with colleagues here at the hospital who were really convinced that they needed to get Pfizer early on when we were vaccinating healthcare workers. They couldn't have AstraZeneca, they have to have Pfizer. And a whole heap of those people have come to me and said, can I have AstraZeneca as a booster? Which is about the change in understanding of how effective this vaccine is, the durability of effectiveness it gets. You know, I think, just to jump in a little bit too, to say that if you're waiting for a Pfizer, if you're sitting here listening to this, you know, Sharon's point is right. You have all of these kids ahead of you in the queue who don't have a choice. They can't have AstraZeneca. There isn't at the moment a whole heap of supply of Pfizer in my freezer. So you are going to be able to get your 2 doses of AstraZeneca without a doubt before, if at all, Pfizer becomes an optional extra for people who are over the age of 60.
Such a great message, Janine. Thanks for making it. And before we leave the variants of the vaccines, because there are so many other issues we need to get to, Vlad via live stream has asked, can any of you, and please whoever wants to buy in on this, comment on the Novavax vaccine that's going to arrive in Australia at some stage and its comparison with the other vaccines here already?
I speak briefly. The Novavax is different to the other platforms because it's a recombinant protein. It's actually more of a traditional vaccine than the adenovirus vaccine and also the mRNA vaccines. The problem has been that it was well behind the others in terms of its clinical trial, and then with manufacturing being geared up from a relatively small American company. They are not yet licensed in Australia. The TGA think that that license, if it were to occur, and obviously they're not going to second guess the data, they'll assess all of the data on its merits, but if it were to occur, it would be sometime towards the end of the year. So in terms of availability for Australia, it isn't going to be until next year. And therefore, it's more than likely going to be a candidate for a booster candidate. If we are going to have boosters, then potentially having that vaccine. The clinical trial data from that vaccine, which has not yet been published in a journal but has been released by the company, it does look very, very good. It looks as good as any of the other vaccines, including Pfizer and Moderna, but it remains to be seen what its place will be here in Australia.
Got a question now, which will be of great interest to the people who run businesses who are watching. It's from Nick. He asks, government roadmaps released so far have included a bright line between rules for the vaccinated and the unvaccinated. In reality, Nick says there'll undoubtedly be something of a grey area where exemptions will be sought by those who are vaccine reluctant. So Nick asks, how do we see this being managed from a public health perspective, and are genuine exemptions, casting ahead, likely to be rare?
I think we're just working through the mechanics of it, but I think what's clear from the Victorian, the New South Wales, the federal government is there will be certain things that vaccinated people can do, and non-vaccinated people will not be able to do that. However, there are certainly, you know, everyone has to go into a supermarket, for example, everyone has to go to a chemist, etc. And so what other countries have done, and I think this is a really interesting strategy in Germany, they have this program called the 3Gs, which is you either, in order to enter a store, you either have to be vaccinated or get some German word beginning with G, get vaccinated. You've either got to have proof that you've had prior infection, so you have immunity, or you have to have proof that you do not have COVID, meaning a negative COVID test in the last 24 hours. So I'd expect over time we will have, you know, sort of systems in place like that, because of course, you know, there are very few, I actually don't really know of any medical exemptions for vaccination, I'm going to be completely honest. But there will be some people that don't want to be vaccinated. But we will need to develop a system that can cope with it. But, you know, and actually we were just talking earlier with Paul Guerra about things that are, you know, that are absolutely essential. You know, everyone has to go to a supermarket, for example, but then there'll be non-essential stuff like going to the football. Well, you know, we will see a system where vaccination or prior and evidence of immunity will be needed. So I think we're still working that all out.
And
but we may use testing for certain situations. Okay. You know, evidence that you've got a negative test in the last 24 hours, but that's still, none of the mechanics of that have been announced yet. Sorry,
Margie.
No, I beg your pardon. I was just going to add that ATAGI has worked very hard on developing with a working group the medical contraindication form. And as you just said, Sharon, the list of medical contraindications is incredibly narrow. There's about 4 rare clotting syndromes associated with a contraindication to the AstraZeneca vaccine and very few for Pfizer. Really, severe anaphylaxis to a previous vaccine dose is pretty much the main medical contraindication. So, as you're saying, to get a medical contraindication is very, very difficult, and it will make it hard for people. So just to be upfront about that. There are some situations where people may be granted a special medical exemption, but it's a complex process and it's a very narrow range of conditions.
And quite a few questions from those either running businesses or those who go out and about and deal with business owners. And I'll distill it into one overarching question. And Terry, you might want to have a go at this. I know you're all public health experts and may not necessarily come at it from the way that the questioner is asking, but how do you go about mandating vaccinations in the workplace, in this case, anywhere, once we get through the vaccination effort?
In my work, I try to, as they say, stay in my lane, Michael. The politics of this is incredibly complicated. The principles of mandation are well articulated, and some of our colleagues have published this in the Medical Journal of Australia. And certainly you can't even think about mandating vaccination if there isn't enough vaccine to go around. That's madness. That if you're telling people they must be vaccinated and you can't give it to them because there isn't enough is a very bad situation to be in. So clearly we can't even have this discussion until over the next several weeks when everyone will have full access to vaccines. The principle, though, in terms of protecting not just yourself, but protecting the people around you is where this boils down. And I think those principles, fair-minded people need to understand. It's not an intrusion. I don't see it as a civil rights issue or an intrusion on your body and that sort of issue. It's a much more nuanced issue that all of us as citizens and also as members of the community need to be aware, and also have that discussion in the context of an emergency. As we said right at the very beginning tonight, we're not playing games anymore. This is serious business. The economy is teetering. People will die when we open up. We really need to understand that even though we're trying to get to a situation of having manageable numbers, we are still dealing with a virus that kills people. And everyone's contribution to that is not a trivial civil contribution. Everyone needs to share that responsibility. Getting to herd immunity with this Delta variant is going to require, anything approaching herd immunity is going to require coverage of around 90% or higher. So let's not fool ourselves. This has to be the whole community turning its shoulder to this. There are very, very few medical contraindications. And so this is something that we all have to take very seriously.
I saw Paul pop up there recently, before. He might want to wrap up his thoughts as we close the session. I want to move on to kids. Paul, do you want to quickly buy in on this before we leave?
Yeah, look, I think it's going to be a difficult conversation, but we effectively need the governments to lead here. What are they going to rule in as needing to be double vaxxed or tested to get in versus unvaxxed to get in? And I think Sharon summed it up beautifully. There'll be parts that we classify as essential services, and that'll be things like food and medical that I think everybody, whether you've been vaccinated or not, should be able to have access to. And then maybe there's some opportunity for things like events and restaurants and non-essential items where you might need to be double vaxxed to be able to get in. But we need leadership here from state and federal governments to rule in and rule out what circumstances will rely on that.
Thank you, Paul. Question from Michelle that's just come in. If you have had COVID, do you have natural immunity and therefore do not require a vaccine? Who'd like to jump in on that?
Yeah, so the current recommendation is, we would anticipate, and this is what we've seen, that once you've had COVID, it's very unlikely to get it a second time. Very unlikely, but not impossible. And certainly there are cases of people who have had COVID more than once, incredible, bad luck and what other things. So the current advice is that if you have had COVID, you should consider having vaccination if you haven't been vaccinated beforehand afterwards. Exactly when is a little bit unclear, but somewhere between 3 to 6 months after you've recovered from your illness is probably the best time.
I would even be a bit stronger about that, because we know that if you've had COVID before and you get a vaccine, you get supersonic antibody response. You get the best antibody. So if I had COVID, I'd want to be getting a vaccine. It will give you better protection and you get the best protection that we've so far seen.
Okay, I've got a list regarding kids and vaccine, as long as my 2 arms. Let's dive into it now. And let's start with a very simple question, very common question. Do we really need to vaccinate healthy kids who are not immune compromised? Margie, you want to kick off?
Well, this has obviously been a very hotly debated issue, and we've seen governments make different decisions. We've seen the UK bring in, through the recommendations of their body similar to ATAGI, the JCVI has recommended a high risk strategy, and now only a 1-dose strategy for healthy teens. So it's reasonable that people are a bit confused. We here have recommended now for all healthy teenagers for them to have 2 doses of an mRNA vaccine. So that's either the Pfizer or the Moderna vaccine. And really, there's 3 main reasons why you would vaccinate kids. The first is direct protection. And we're very fortunate that still, even with Delta, illness in kids is overwhelmingly mild. We know nearly half still are asymptomatic if they get infected, and severe disease, which is mostly sort of like pneumonia or dehydration that might require admission to hospital, is very uncommon and occurs in about 1% of kids who get COVID illness. There are some rare other complications, such as that multi-system inflammatory syndrome in children. Super rare. In Australia, we've only seen 4 of those so far in the whole pandemic nationally. And then there's this question around long COVID, which is another discussion, but essentially the jury's a bit out. We don't understand it well. The studies haven't been done well. We don't have a uniform definition, and we don't have controlled studies where we're able to compare to a control group. But essentially with kids, you've got all of that to weigh up around direct protection, and then their role in transmission, which unfortunately the risk there is that they will get infected and transmit it to their unimmunised parents or grandparents, and that's the risk to them. And then the last reason, and some may argue the most important, is for them to get back to school in areas where they've been in lockdown or exposed to long periods of homeschooling, and that they can get back to their lives. So, and that in fact is one of the main reasons that the UK have now brought in their recommendation for that 1 dose, is to help kids get back to school and be back at school safely. So it is a very complex discussion, but I think Australia's made the right decision in recommending 2 doses for kids for all of those reasons.
Quite a few questions along the lines of where are we at with vaccines for children 12 years and below? Where does that stand at the moment?
Well, at the moment, we don't have any clinical trial data in children under the age of 12. We're expecting some of the data from those trials again with the mRNA vaccines towards the end of October, September, and then again a little bit later in the younger kids, sort of 6 months to 5 years. So, we may see countries like the US looking at that data and making recommendations towards the end of the year, but I wouldn't expect that we would have a vaccine in Australia for children under the age of 12 until early next year, and that's only if the clinical trials show that they are safe and work well in kids. So there's quite a long way to go before that decision can be made to recommend it for kids here under the age of 12.
And allied to that is another question. Is it wise to allow primary school kids back to school before we hit the 80% full vaccination target in any state, and certainly in Australia? Sharon, would you want to opine on that?
I should really give this to Margie, because she's super passionate about it and very knowledgeable. But the short answer is absolutely no problem of them going back to school for some of the week, which is what the plan is in Victoria. But Margie will talk about it because I know this is her area.
And then I'll stop talking. So yes, no, absolutely. And this is a really common question. We don't want parents now, as the roadmap opens up and kids are able to go back to school in a staggered way, we don't want parents of primary school age children holding them back and keeping them at home. As I said, even with Delta, infection in children is overwhelmingly mild and severe disease is uncommon. And everything is being done in the school setting to make sure that they are safe. And what I mean by that is that all eligible teenagers will be vaccinated, parents, school teachers, and then in schools there'll be lots and lots of mitigation strategies. So in kids 5 to 12, they'll be recommended to wear masks. It won't be compulsory if they can manage it. There'll be lots of other strategies around reducing class sizes, hybrid online sessions versus a few days at school. So there'll be lots of strategies in place to reduce the risk of transmission to primary school age kids to keep them safe. But actually the biggest message to give to parents is the best thing they can do to keep their children safe and have them at school is to get vaccinated themselves and their grandparents as well. So maybe I'll hand over to Terry maybe to make some comments.
No, nothing to add to that at all. You've said it well.
I want to get to the issue of vaccines in pregnancy. Lots of questions along those lines as well. Simple one. I'm 23 weeks pregnant, asked this questioner. Should I get my vaccine now or should I wait until I give birth, given I've heard of potential issues with pregnancy?
I would recommend you get that now. Again, having just had to be helping pregnant women. I've had a number come through and go out to the Women's and Monash Medical Centre with COVID. Having COVID and being pregnant or having COVID when you've just recently given birth is not a great situation to be in, and there are significant consequences of that. There has been a whole lot of concern, which I think is understandable. Quite rightly, pregnant women are really careful about what they put in their body and the consequences of that. But there is great data coming out of places that were ahead of us, right? That started vaccinating early and that were vaccinating when there was a lot of COVID. So a lot of pregnant women got vaccinated in America, for instance, overseas, and that shows that it is incredibly safe. There's no reason to expect there to be problems from any of the animal data from what we know about the vaccines, and there's been no signal of problems from any of the people who've been having the vaccine and then gone on to give birth to healthy babies. So I would say that if you're living particularly in Sydney or Melbourne, the risk of having a bad consequence of COVID, catching COVID and getting a bad consequence far outweighs any tiny theoretical risk from the vaccine. And if I was weighing that up, genuinely, that's what I would be advising people.
And I should also just add, there's no recommendation around timing. Any time is safe, and the best time is now because of the consequences of getting COVID.
The issue of possible connection between vaccine and having an impact on breastfeeding is the subject of so many questions as well. A simple question. What research is there on the effect of vaccines on breastfeeding?
Yeah, there's good data, and it shows that there is at the moment no impact on quantity or quality of breast milk, and so there's no reason to expect there to be any problems as well.
Margie?
And also maybe just to add to that with breastfeeding mums, they can have either the mRNA vaccines or AstraZeneca. And as Janine said, there is no evidence to show that it is unsafe in a woman who's breastfeeding. And there is even maybe some evidence to show that the antibodies that may pass through the breast milk could provide some protection to the infant, although obviously we need more research around that in terms of clinical protection. So, and of course, importantly, vaccination in pregnancy also provides protection for the infant by transferring antibodies across the placenta, so that fabulous 2-for-1 protection.
A question from Annie that's popped up regarding the conversation around herd immunity just before. If the reality for possible herd immunity is 90% immunisation for the entire population, shouldn't this be stressed much more often to the public so we don't get any unnecessary complacency, say between 70 and 80 and 80% above the issue of herd immunity? Should that be, I guess, driven home by authorities more forcefully?
Yeah. You go.
Sharon, go ahead.
Oh, no, I was just going to say, I think herd immunity is a really confusing term. I think most clinicians don't really understand what that actually means for COVID. And I think most people in the public don't really understand what that means. What we want with vaccines is people to protect themselves, so that lowers their risk of hospitalisation and death. And also it reduces your chance of becoming infected and reduces your chance of transmitting it. And all of that will lower transmission in the community. These vaccines are not great at what we call sterilizing immunity, completely protecting you from becoming infected so that you can have asymptomatic infection. So these vaccines are not like the measles vaccines, for example, that are brilliant as like the virus never gets through the front door. Well, with the COVID vaccines, they're not as good. And that's why if we're going to rely on the reduced chance of symptoms and reduced transmission, you need really, really high levels of vaccine to protect the unvaccinated. We're not in that position now. The vaccines just aren't good enough. There may be second generation vaccines. I'm quite optimistic we will get better vaccines. Terry's working on a really interesting new vaccine that will be tested in October, the first homegrown COVID vaccine that will be able to trial in Australia. And I think these second generation vaccines may give us better. Basically, the problem is the immunity in the nose. They're not very good, the current vaccines, but they're brilliant at stopping you becoming hospitalised or dying and reducing your chance of becoming infected and then transmission. So the herd immunity idea is a bit sort of not relevant to, I think, to the sort of vaccines that we have right now. If we had better vaccines, yes, but I don't think that's realistically. I think what maybe Terry might add, but I think what Terry was getting at is that if we really want the vaccines to really have reduced transmission, we've got to get, really significantly, we should be aiming very, very high to get as many people as we can vaccinated. But Terry, you might want to add to that.
I mean, it is a meaningful concept. It doesn't rely entirely on having what's called mucosal immunity, but you don't even have to think about this complex term like herd immunity. It's common sense. The more people in the community who are immune and protected, the less virus will be circulating. Would you want to go into a bar where of the 100 people in the bar, 90% were vaccinated and protected from the virus, or would you be happy to go into a bar where 90% of people weren't? Of course, the more likely it is that you're protected is going to produce a safer environment for you going into a group. That's as much thinking as you need to do about it. The more, the better, honestly. But there is some mathematics and something behind this which actually leads to the calculation of those estimates of what that coverage level is, where you do get very high levels, a threshold, a herd immunity threshold, where you do get this protection. The second and frankly the third generation vaccines, which are also in very early trials, are actually of vaccines which are administered into the nose. They're a spray. So it's basically a vaccine that, if it works, will produce what's called mucosal immunity, or immunity where the virus first comes to you and where the virus might be when, if you were sneezing, you sneeze it or blow droplets or aerosolize the virus. And that potentially will be something that would be a game changer, but that's still a way down the track. Just to re-emphasize the point, the 70 and 80% targets in the modelling were there as sort of gates where you could start to safely open up. They shouldn't be our targets for where our population should be aiming for. Our target should be at least 90% or higher, as we do for kids already, for all the existing vaccines. Why the hell wouldn't we have the same sort of thinking now applied to this, is my simple argument. And my worry is that we'll get to 80 and people will think we can now take the foot off the accelerator. That shouldn't be happening. We've got to get as many of the whole population immunised as we can.
Just on this, somebody has chipped in with a question anonymously, pointing out that Israel and Singapore are reporting increase in case numbers and hospitalisations as a consequence, despite having rather very high levels of population vaccinated. Does this not suggest that herd immunity is simply out of reach anywhere in the world? I think that just reinforces the point you've been making.
Yeah, it doesn't, and there is the issue of Delta circulation and the extent to which there's been some erosion of protection from that. And also that circulation of disease is principally in the unimmunised rather than individuals who've already been immunised. But yes, it's still real. But even Israel hasn't achieved those very, very high levels across the whole population. Now, I'm really talking about what we've done for our kids, getting us to that point for all of our population with this particular vaccine.
To a broader issue, I mean, we all, quite a few questions go to this point. We've all seen pictures of pretty full soccer stadiums in the UK, packed rock concerts in the United States. Questions along the lines of what lessons have we learned from other countries that have opened up, not necessarily at 70 and 80% double vax, but in many cases less than that. What lessons can Australia learn from that? And what pitfalls lie ahead if we open up too soon, I guess. Just paraphrasing a few questions along those lines. Who'd like to buy in on that?
I'll have a go at that. I think what we've learnt is that 50, 60, 70 or 80% fully vaccinated is not going to stop Delta from circulating. And that's very much what the Doherty Institute-led consortium of modellers has shown. It's what the many other modelling that's been done around the country, that we have, because of this fact that you've still got 20% of the community susceptible, and it's not enough to protect them at 80% double vax. So countries like Israel and the UK and the US went, bang, we're open, and we've learned that that doesn't work. And so what the advice to government is that we've got to use these other levers, which we know we can do really well in Australia. Open up with at smaller numbers is what we're now seeing, tens to hundreds, not thousands, which is the most recent modelling, and use these other levers of test, trace, isolate still, which we've done extraordinarily well here, better probably than almost any other country, and also some public health measures that we can dial up and down. We want to dial them right back down and stop lockdowns, of course, but if there was pressure on the hospital system, we'd have to bring that back in. So the main message is vaccination alone at the levels that have been achieved in most countries is not enough to stop these big outbreaks. You need other levers. Does that mean you can never have a big event? No. In the Victorian roadmap, they're talking about big events, but there'll be measures in place, such as only vaccinated. If at the moment they're saying only vaccinated. Some of the big events in Europe are requiring a negative test. QR codes, zoning, not allowing people. So they won't be the same as before. We all want our lives to go back to what they were like before. We'll get close to it, but it won't be back to how it was.
A couple of questions along the line of treatments. I'm just citing one question here. Do we really need vaccines? I keep reading about these treatments you can take if you're unfortunate to get COVID. So why do I need to get vaccinated? Anybody want to respond to that person?
There's lots of different treatments. There are treatments available now, or strategies is probably the way that I would phrase it, that we do use for people with COVID. Anti-inflammatory medications, steroids, very commonly, medications that help reduce viral replication. And then obviously we've heard a lot recently about monoclonal antibodies. So essentially giving someone an immune system instead of using a vaccine to train their own immune system. And none of those things are perfect. None of them are in abundant supply, particularly monoclonal antibodies and medications that are based off them. I think they will be part of our armament to help protect particularly the people who are not going to respond to the vaccines. So I really see a lot of those therapies being most used in people who are being treated for cancer, in elderly people who don't have a very good immune system. That's where it's going to be really useful. But I would recommend that you try to avoid needing to be treated for COVID is the better outcome. We have no idea whether these medications will impact the incidence of long COVID or what will happen down the track from them as well.
I'll ask this question. I'm pretty sure I know the answer to it, but it's the subject of quite a few questions. Does anyone on the panel believe ivermectin to be a good alternative to vaccines?
No. Simple answer, no.
No.
Good. So I'm going to turn it around again, because people are asking in the pre-registered question. I've read this, and Facebook said that, and my great aunt said this. What are the dangers? of this particular treatment for people believing they're going to take it and not get COVID?
So ivermectin, actually the work on ivermectin started at the Doherty Institute back in March, where it showed that it can block the virus from replicating in a test tube model. But it showed it at super high doses that you could only achieve in a test tube model that don't come close to what you can achieve when you give ivermectin to someone. We've used ivermectin for years to treat parasites, not to treat viruses. So it's widely used, it's very cheap. And there are many clinical trials trying to work out whether it can be used as either a treatment or a prevention strategy. But so far, there have been no studies that are large enough and have clearly showed that they're of benefit. And so my view is, well, first, certainly as a doctor, first do no harm. So why take something that could potentially, all medicines have side effects. Ivermectin's at least cheap. People aren't wasting money because it's cheap, but there's no evidence that it yet works. I answer with that, I didn't mean to be flippant at all saying no. There are still studies assessing whether it can work or not, because wouldn't it be wonderful if it worked? Because it's cheap and so widely accessible, and that's what we so desperately need in COVID, particularly in low middle income countries. But at the moment, there's no evidence that it works in prevention. There's no evidence that it works as a treatment. All medications have side effects, and it's still an unanswered question, and many very good groups are trying to answer that question with large clinical trials, not currently in Australia, but especially in the UK currently.
And speaking of the misinformation campaign, I'll toss this one to you, Margie. I know you touched on this broadly in the past about vaccine reluctance, vaccine hesitancy. Question, how do I combat misinformation from anti-vaxxers, some of whom, sadly, I know that vaccines can alter your DNA, vaccines can cause infertility? What is the best user-friendly way? And people are writing, these are loved ones, these are family members. I don't want to get too angry, but what is the best way, civil way of sitting down with somebody and trying to dispel these dangerous myths?
Well, the first thing to say is that, especially a conversation with a family member or loved one, is this conversation is not worth jeopardising your relationship with them for. And people have a right to express their opinion. And so, whenever you have a conversation with someone who's expressing concerns, the most important thing is to try and understand where they kind of sit, if you like, on that vaccine hesitancy spectrum. Are they really, vehemently up the other end and anti-vax, or are they sitting more in the middle, where I think most people sit and genuinely have questions and concerns? And then give them an opportunity to express what they are. Sometimes people tend to mention their most important question or concern last. And then I think really what is our role is to share trustworthy sources of information with them, point them to reputable information. People are overwhelmed with this tsunami of misinformation online, especially on social media. So helping them find good sources of information to answer questions. And then I always come back and actually remind them about the disease and how severe the disease is and why we are vaccinating, so that we're not totally focusing on the vaccine. And then recommend that I think it's the best thing to protect them. And if they're not ready, then the important thing is just to kind of leave the door open. Sometimes it takes 2, 3, 4 or more conversations. But if people don't feel attacked or judged, they will come back. They'll do their own sort of research. They may discuss it with other people and then hopefully revisit that decision if they're not ready. But it's certainly not worth jeopardising your relationship with a family member.
Good advice. Sharon, I know it's been an issue through the pandemic. Do you see it becoming less intense, the misinformation campaigns, as we get through the vaccination process?
Yeah, I'm not sure. I think there's a world out there of a lot of misinformation, and many of us just mix in our own universes and echo chambers. I think the misinformation is alive and well here. I think what's happening is the vaccine hesitancy is getting less. We've certainly got good information about that, and that's for a number of reasons. The people that Margie's talking about that were hesitant are able to now access information on billions of doses. That's very reassuring. Because we're now at 48% double vaccinated in Australia, many people will have a friend or a colleague or someone they trust who's got vaccinated. That will help them. And then also the reality of COVID is that now, that is also really driving vaccination. So I don't the misinformation, I don't see that stopping. It will probably escalate, unfortunately, just the world we live in. But the hesitancy in a place like Australia is reducing, and that's great. And sometimes people just need more time to take on new, this sort of new world that we're kind of rushing through. That's people have got, concerns for all sorts of reasons that Margie spoke about, but the data is just showing that the hesitancy is reducing. We probably need to understand that even at a deeper level, because I'm sure it's very variable in different pockets of our very diverse communities.
Absolutely. And just to add to that, that in some different cultural groups, there's real historical mistrust, or there's really deep conspiracy theories. And so, as I said at the start, that often takes their own community and cultural and faith leaders to reach them and to address that sort of misinformation, not outside people. But that all comes back to that really good community engagement that I mentioned at the start.
We're nearing the end of our conversation, and I know there have been a lot of serious issues that have been expertly addressed by all of you, but I want to try to finish on a bit of a brighter note. We are progressing well through the vaccination process. It got off to a pretty awful start, we all know that, but as more Pfizer and now Moderna doses are arriving in Australia, uptake is increasing, which is great. I just want to go around the grounds as we finish off, starting with you, Janine. To ask all of you, how do you rate where we are at the moment? How confident are you that 2022 is going to be a much brighter place to be, particularly for those people living in Victoria, New South Wales and the ACT?
Oh yeah, I'm an optimist. I agree with Sharon. It is the vaccine program is escalating. It is gaining momentum. People are getting on board, and you can see that in the numbers, right? I see that in my clinics. Our clinics handed out 70,000 doses of vaccine last week. Wow. Back at the very beginning, I think perhaps even when we first did this the first time around, I was sort of celebrating the fact that we'd handed out, I think, maybe 20,000, and we were all thrilled. And now we are absolutely running through that. And that says to me that if we can do this, as Sharon said, it won't be normal back to 2019 life at the start of the start of next year. But I think it will be a life that we can all get back to the important things that matter with just some little tweaks. So I'm pretty happy that next year will be a better year.
Margie?
Yeah, thanks, Michael. I mean, as a mum of 4 kids and a paediatrician, I'm really optimistic now that we can see a bit of a light at the end of the tunnel of getting kids back to school, getting kids protected. I'm looking forward to seeing that clinical trial data in the younger kids and hopefully giving that option, particularly to high risk and vulnerable children under the age of 12, and giving a lot more surety to families that we know are still worried about those kids in particular. So I do feel really optimistic. I share Janine's positive outlook, but I do think we've got a long way to go. And I think reaching that last 20%, as Terry's been talking about, is going to be hard. And we still have to roll up our sleeves and really do the hard work and understand in different community groups, what are the questions, how can we overcome the barriers, and just to remember that actually it's very often not hesitancy at all, and that there is still significant supply and access issues, and people who desperately do want to get vaccinated who for whatever reason are still struggling to get an appointment. So there's a lot of work that we still need to do, but I believe that we are getting there, and I'm looking forward to seeing a brighter 2022 with kids back at school happily.
Terry, over to you. I think you're muted.
No.
There you go.
I'm not. Can you hear me, Michael?
Yes.
A year ago, we weren't sure we'd have anything. We didn't know we'd have any vaccines that were going to work. The clinical trials were just being done. And then early this year, we had the vaccines, at least theoretically we had the vaccines, but we didn't have them here in Australia. But now for the first time, we are empowered because really only in the last month or two, the vaccine supply has really now arrived. And so what that means is our destiny is now in our own hands. No one can do this for us. We all have responsibilities as citizens. Business has a responsibility to help make it work, to help them recover as well. our communities do, our governments do. This is a collective responsibility for all of us, and I think we can do it. Australia is very good at getting organised and doing stuff, and I think we can do that. I'm optimistic we'll reach that. It won't be problem-free. There'll be new challenges, but I'm very, very optimistic we're going to get there.
And Sharon Lewin, the last word to you.
I agree with what all the other speakers have said. 2022 will look very different. Australians have a history of taking up vaccines and believing in the science and trusting their doctors and the health advice that they're getting. But I also just want to end on saying that this incredible scientific advances that we've seen in the last 18 months, 20 months, we're going to see them continue in the future. So science isn't going to stop. We will see better vaccines. Our vaccines are pretty damn good right now, but we could even get better, and we will see these next generation vaccines. We've got a few treatments up our sleeves, but none are absolutely perfect, and we'll see better treatments, and treatments may well play a role. A simple tablet as an antiviral instead of an antibody infusion could make a real difference. And we've relied heavily in Australia on the traditional nasal swab and PCR test, and we're going to use all these other new innovations around testing. So, it will be a composite in response. High vaccine rates, absolutely fundamental, but these new advances in science will keep happening. There's never been so many people affected by this one disease, and so much investment in trying to get scientific solutions to get out of it. But right now, we need people to take responsibility for what we have available to them right now, which is, this access to a vaccine, which will on its own already transform our lives.
And you had a great, just before we finish, great suggestion in a conversation earlier today about all of us who have first or second dose becoming vaccine ambassadors, selling vaccines, encouraging family members, friends to get vaccinated.
Yeah, if every person on this call went out and got one, maybe 2 or 3 more people vaccinated, how great would that be? We should all be vaccine ambassadors. If you've had,
I've always wanted to be an ambassador. There you go, Sharon Lewin, Terry Nolan, Margie Danch, and Janine Felling. Thank you so much. I know I speak on behalf of everybody out there watching. It has been such an informative session. I speak about this stuff every day and have been doing it every morning for the last 18 months. I've learned quite a bit this evening, and I'm sure lots of people out there have as well. So thank you. And I want to now turn over to Paul Guerra from the Victorian Chamber of Commerce and Industry for some closing remarks as well. Paul, I think you'll agree it has been such a fantastic session.
Just brilliant, Michael. Absolutely in awe of the panellists today and what we heard. I've had a lot of feedback on text. Across the board, the response has been brilliant. A couple of key takeaways for me. The time for waiting to get vaccinated is over. We all know that, but having it reinforced is really important. We need high levels of vaccination to stay out of this for the longer term. And as Terry said, that target should be 90% or higher. So let's get to 80%, but don't stop there. Let's get a higher than 80% as we can. Janine, incredible, coming off the COVID ward today. And as you said, almost entirely made up of people who aren't vaccinated. It's a sobering thought. So for now, it's a decision between getting COVID or getting vaccinated. The time for hesitation is over. The vaccines are safe. 5.7 billion doses have been delivered globally already, and safety is monitored all the time, every day. We heard about the third dose. It's highly likely, but details are still being worked through. It's unlikely all of us will need the third dose, though. AstraZeneca is a good vaccine. History is showing us that it's holding up well. Great thing about AstraZeneca is that we have plenty of supply. Mandating vaccines, that'll still need to be worked through. The model that could work, as Sharon suggested, is being used in Germany, labelled the 3Gs. Get vaccinated, prove that you've had COVID, or get an immediate test to prove that you don't have COVID. The principle is that everybody should have access to essential services, though. Vaccines are safe for pregnant females, and it's also safe if you're breastfeeding. And perhaps to finish, the message from Terry is clear. We are not playing games anymore. The economy is teetering, and this is a deadly virus. Everybody needs to share the responsibility to navigate a way out, and vaccines are the way. So then, Michael, brilliantly moderated. Thank you for bringing it together so professionally as always. I did feel like I was transformed back to breakfast this morning. You did a wonderful job. Thank you. Sharon, Margie, Janine and Terry, you're just fantastic. Your experts and insights, just so appreciated. We're so lucky to have you in our state. And Janine, to have you join us straight from the COVID ward is very much appreciated. I can't imagine what your day would have been like today. I'd like to thank all the audience members who came forward with their questions. Just brilliant. You kept the session running and kept us all engaged through it as well. So let's keep the conversation going. Please pass what you have learned tonight to your friends, your family, your colleagues, and point them where they can find further information, credible information. And as our panelists have said, the more we talk about the facts with experts, the better we will be. And I'm saying real experts, not Facebook or social media experts. And they look like the doctors or our panelists today. Let's all go and be vaccination ambassadors or COVID ambassadors. Finally, if you'd like to know more about us, the Victorian Chamber, please head to our website, www.victorianchamber.com.au. And with that, thank you. It's been an honour to be part of this. And well, we've got a way to go, but isn't it great to be guided by the experts on our panel today? Thanks, Michael.
It is indeed, Paul, and I appreciate your fine remarks there as well. In closing, again, thank you for everybody out there tuning in virtually for this information session. A reminder, the latest information on the vaccine rollout can be had at the click of a few fingertips at health.gov.au. A huge thank you to the philanthropic supporters of Doherty and all the fabulous research institutes in Melbourne. I've said this before, I think it is the world's best biomedical research institute in the world. So a huge thank you for everybody who was behind that, and certainly in financial terms as well. Just finally, if you'd like more information, concise information on everything to do with COVID and vaccines, highly recommend visiting the University of Melbourne's new site, vaxfacts.org.au, which happens to feature Margie Danchin at the moment, answering all your questions on the vaccines in short, digestible videos. And if you haven't already tuned in to the Doherty Institute podcast, I highly recommend you do so. It is great listening, very informative. It's called Infection and Immunity, Evidence Explains. It's dropped every fortnight. They have experts providing insights and evidence on everything to do with COVID vaccines and the fight against this dreadful virus. A reminder, the event, tonight's event has been recorded. You can catch up with it a bit later on the Doherty Institute's website. To our panelists, Paul, thank you all for your time tonight, and to everybody watching, have a great evening, and until part 3, then, goodbye.